that's the, I have no idea what that is.
Oh, I'm recording it so we don't have to take notes here.
So that's kind of called the equator. So you want it roughly to center approximately there. The glenoid is pear-shaped, so it's not an exact, but essentially anything above the equator, you although that where they put that equator on the picture is not exactly right, but
Okay.
anything above that, you're not repairing using this device, because anything above that is considered a slap lesion, and you really don't need specifically distraction to repair a slap lesion because you get that access superiorly. So anything below that, but if you consider the glenoid a clock, you don't repair really anything along that equator. It's below that, starting at about 4 to 5 o'clock is a real Bankart lesion, and then going about to 7 o'clock. Anything superior to that is not considered clinically significant.
So this is the area that you want to target?
Yeah, maybe your 4 o'clock could be a little closer to 3 or 3:30, but somewhere around there. If you're repairing above there, those are considered if the labrum is detached above there, it's considered a normal variant. It's called a sublabral hole. So if you, in the old days, people used to think that that was an abnormality and repair it, and it over tightens the joint and leads to arthritis. And then that was pointed out by Steve Snyder at one of the meetings that his fellow at the time, Don Buford, presented that is a normal variant. Unfortunately, at that meeting up on the podium, they decided to name it the Buford complex after this fellow, and he was ruthlessly attacked by the panel that you don't name normal variants, particularly after yourself. So that was a pretty ugly meeting.
Wow. I know Steve, and I know I've been in surgery with Don in Dallas. Yeah.
Yeah, I was at that meeting, and it was a ruthless attack on the inappropriateness of named normal variants. So that kind of went down in flames. But that is a sublabral hole, and there's another component to the quote unquote Buford complex, which I don't think people call that anymore. So you don't repair that. So it's anything below that. So you don't worry about distraction above that. But what we really want to do is, if you could, which I'm not suggesting, if you could create a cup, or if you think of holding something in the palm of your hand, sort of like this, here's my camera. If you could create something like that to grab the humeral head and then push it out, then if you consider your fingers would hold the humeral head and it wouldn't be able to migrate. So we want some diminished version of that where there's no fingers, but there is a relative increase in size to create a sort of a pseudo trampoline with edges, so to speak. So we want to have the center of it be semi-rigid, because we don't want it to damage the articular cartilage in the humeral head. So we want to distribute the force in a somewhat of a trampoline manner, but we don't want it to be so displaceable that it doesn't really distract the humeral head adequately. So that the tension across there is going to be based upon the material we use and the circumference, how rigid that is when it's inflated to be able to allow enough displacement to maximize the contact area between the humeral head and yet displace it such enough that whatever the humeral head capture is that it doesn't protrude underneath the device such that it blocks the access to the repair devices. So it has to, you have to allow enough access underneath the device once it's distracted to choose whichever instrument you're going to use, whether it's a scorpion or a suture lasso, to slide underneath there. Because if you can't do that, then the device is not helping you.
So there's a little tunnel inferiorly there where you have to get instruments in and out.
Yeah. So the device design that is purely an oval, I think has some advantages in that it's more of a pseudo dish. In other words, like maybe a sixth or a fourth of a dish. But it may not allow to have pathways underneath it as accessible as the design with the three, I guess, pseudo spheres at the corners. So I think one hurdle is, how do we get this? What happens when you inflate this? I mean, what does the sequence of inflation look like? And that may present some challenges, because depending on the connections, I mean, the connections between the balloons have to have some pathway through them to inflate all the balloons. So I don't know whether, if you have that the tube exiting the superior balloon at 3 o'clock, if you push air into that, or saline, or whatever you're going to use, is that going to preferentially inflate the superior balloon versus the two inferior balloons? Because that also is not going to be ideal. You would preferably inflate, if anything, the two inferior balloons more than the superior balloon, because that's where the labrum is. But ideally, all three would inflate equally. The reason why inflating, if you were forced to choose inflating the inferior balloons preferentially, say, 60% versus 40% of the superior balloon, is that theoretically is going to take the humeral head and push it superiorly, which is ideal because the portholes into the glenoid are going to be about where that notch is, maybe a little bit above there. So any displacement of the humeral head superiorly is preferable to inferiorly, or if it directly laterally displaces the humeral head, that's perfectly fine. The only exception to that could be how you get the uninflated device into the joint. So the only portholes, I mean, there's a limited number of portholes you can use without causing neurovascular damage. So where that tube is exiting superiorly, that's the pretty standard superior anterior porthole just underneath the biceps and above the subscap. That's pretty much the standard porthole that everybody is going to make when they start the case. The posterior porthole is back. In other words, where you put the camera in that the balloon at about 7, 8 o'clock, just above that is where you almost exclusively will make where you put the camera in, that's where your porthole is. So
This one?
yeah, so, yeah, that's about where that porthole is, and that's porthole is. The anterior porthole, you could put a little higher or lower, but it's constrained by the subscap, the inferior aspect of it. So it's between the bicep and the subscap, and where you put that, that's sort of dealer's choice. So when you're putting the balloon in, the question is you're probably going to put it in through that porthole that you're drawing now. And so the question is there a rotational issue? In other words, when you put it in, is that tube going to cause it to rotate clockwise? The only other option that comes to mind is if you look at that superior balloon that you have, yeah, again, I don't have access to the little pin that you have on there, but if you look at the balloon, or I should say the sphere at the top of the implant.
Yeah, Dr. Weiss, I think it may help, like if you kind of click on the, I don't think you can see this, but on the screen, like you have two windows for the zoom, right? Or you just have one window for the zoom and you see something called annotate there?
So let's see, I'm looking, there's like a pen on the bottom, annotate.
Yes,
Okay,
there you go.
okay, all right. So if you look at this balloon here, I don't know how you erase that, but
Erase is on that side where you have almost like it should be a toolbar that opened up on the left side.
let's see. Oh yeah, there we go.
So there's an erase, so you have to use that to
Mouse,
erase.
text, draw, stamp, arrow, erase. There we go. Look at that.
And then
Okay.
I'll erase all my, I can erase mine too. So and then you can go back to the pen and then draw. You have to hold the mouse. You have to hold the mouse down. Yeah, there you go.
So if you look at this balloon, if you go straight up here, there is a superior porthole that's called the Navager porthole. So that allows you to come straight down into the glenoid. So if you're putting the balloon here and you make this tube superiorly, then this tube is completely out of the way, and you can orient this balloon as you see it in this picture because you're putting it straight down from the top. So you could use a Navager porthole, which pierces the musculotendinous junction, and put it in this way. If you put it in the front here, you might be able to get the same outcome. Understanding the shortcoming of that is that you have now used up this porthole, which is your working porthole. And so the only way around that is once you've taken that in, you can then remove this porthole and then you can put it back in and keep this tube outside of the porthole. But there's going to be pressure on this tube, so you probably have to inflate it first and then put the porthole back in. Whereas if you put it in an Navager porthole up here, this tube, if you is rotated up here, it's completely out of the way of where you're going to be working, because you're going to be putting in a suture lasso or a scorpion, and you're going to come down here and suture here, suture here, suture
We
here.
can't see your annotation, but I'm able to follow you. Yeah.
Oh, okay. So you're going to come in here and then you're going to put your suture lasso here. And then you're going to sew here, and then you're going to sew here. So if this tube is in the way, that's going to create a problem. So theoretically, if you did it, you could take the porthole back out and then put it back in with the balloon outside the porthole. But if it constrains this too much or tears it, then the whole thing will deflate, because the cannulas all have threads on them. So you can screw them in. They're not sharp, but if this is not made of a tough enough material, you could cut into this. So you'd have to inflate this first and then put the cannula in. But if you put it up superiorly up here, that would take that out of the picture. So that's a design consideration, understanding the technical issues about how you go about fixing this, how you about fixing a labrum, which is really what this is for. So that's one thing. So I think making a, I know of the designs that you have, here's one. I know that there's one that has the smallest possible footprint. I think that was at the top somewhere. Yeah, I don't think I can scroll.
No, you cannot, but I can walk you through. Okay, let me go through.
So there's one that has, yeah, the donut, the horseshoe. And then there's, I'm not sure what we should call the third one. Maybe you gave a name to it, the one with the 3 spheres on it.
I call it barbell. Yeah,
3 points design. Okay.
3 points.
Sounds like a fancy hotel.
So that's this one here.
Yes.
Low profile.
So some, yes, so
So this
the,
one.
yeah. So I'm not sure about this neck length. That may be too long of a neck, so I would probably try to bring this a little bit superiorly, and then the trampoline, I'll call it.
Hmm.
So if you've got a golf ball and you're trying to bounce it on your fingertip, you're going to have a bad time. It'll just slide off. So that area of the trampoline has to be, you'd think something like that. I don't know the exact ratios, so that there's enough point contact to control the humeral head so it's not sliding out anteriorly or inferiorly, but also there's not too much pressure per unit area to damage the cartilage. I don't think that is going to be a real problem, because we put enough pressure on the humeral head passing instruments. But it is something to think about. So getting it, I don't think it has to be exactly right, but the priority is enough room so that I can put my instruments here and here around it, and enough trampoline area, which would be 2 pi r to be technical, so that it captures the balloon. And the balloon captures or the trampoline captures the humeral head and controls it. The 2 pi r is not exactly correct, because if the trampoline displaces somewhat, the 4/3 pi squared is, I believe, the area of a sphere. So it's some combination of, if it displaces somewhat, then there's additional surface area. So one thing is, I can see that I have to go grab the battery, it says is low, and I think we probably have more to talk about, would be my guess. All right, so let me go grab the charging device, because I charged this before, but the battery is low. So this will take me about 30 seconds.
Okay. All right. So in the meantime, I'll try to sketch this of what he's talking about.
Is the intent to have the instrumentation below the trampoline?
Yeah.
Yeah, I think it's also the underneath the trampoline too. Like that's the reason why we have this
Yeah, I'm sorry, that's what I
space.
meant. Yeah.
This space here.
Yep.
So I'm kind of trying to.
Okay, so I've got, all right, so so I'm not sure
Is it-
exactly what the right answer is, and I think the only
Is it something like this?
only, but I think yeah, so you could do you know, depending on what sort of computer capacity you have, you could do FEA on it if you guys know. And that might give you some, I mean, you've got to have, a reasonably powerful computer. In
Yeah.
the old days, I would say you need a Spark workstation, but that just shows how much gray hair I have. So, I guess Tiger probably knows what a Spark workstation
Yeah,
is.
I remember Spark.
Um,
Nowadays, the comp speeds are pretty high for, you can run FEA on anything. Yeah.
So you could do, if you are, I'm not skilled in that art, but you could do an FEA on it and get some idea. I'm not sure what parameters you would put in. But I think sort of so one is deciding what material does this need to be made of, such that when it is deflated, you can fit it through a cannula. Because if this is made of, I'm just going to say like a rubber type material, like not like a tire, but
Like polyurethane.
yeah, something, you're not going to be able to compress this enough to get it through the cannula. So I think you've got competing and disparate material properties. You need something that can be deflated to the size of a cannula. And I think I sent you the diameters of the cannula at some point. Yeah, that's courtesy of Arthrex. Actually, I don't memorize the size of the cannula because, you have to orient these towards the low IQ of orthopedic surgeons. So they make them different colors. So the orange is the smallest one and the purple is the large one. You want to be able to get this through a purple cannula. There actually is a larger one, but I've never used it and I've never seen it. The idea being, if you put a cannula in that is so big that it obscures your working area, then you might fit something larger in, but you defeated the purpose of the cannula. So you might be able to put the so-called green cannula in, which is the largest one that they make, put the balloon in, remove the green cannula, and then drop a purple one in. The problem with that is that the skin incision has to be big enough to put the largest cannula made in. And then when you put the smaller cannula in, fluid is going to egress out around the cannula, and it's going to create a mess in terms of soft tissue swelling, and you won't get good sufflation of the joint. So you sort of have to be a little careful about the size of your incision. So the material has to be compressible enough that we can get it in there, but it has to be firm enough that it is able to hold and displace the humeral head laterally. So I think those are two really confounding factors. So if the material is like, when you go to a kid's birthday and they have the balloons where there's the magician who makes like all of the like different shapes and dogs and stuff out of it, that will definitely be able to get into the joint. But I think inflating it, it'll either burst, or when an instrument passes by it, it'll tear and deflate. So there has to be the material has to be rugged. There's probably a better word than that, that when I'm passing instruments, that some of them have, like a suture lasso has a really sharp tip to it. I don't think you want to have this such that you keep poking it and it deflates. That's going to be the last time anybody uses it. Like, I have to put this in 3 times. This is torturing me. Just get it out of there.
Yeah.
So it has to be somewhat puncture resistant. It has to be deflatable enough we can fit it through cannula, but it has to be firm enough that when you inflate it, it doesn't start stretching out like a pancake. Instead of pushing the head laterally, it just gets squished and just increases its size. I guess the pancake is the only thing I can think of. So I think if somebody knows material science or the options, or perhaps if we have a subcontractor who is going to make the balloon for us, we can ask them. They probably have expertise in materials.
Right.
So I'm just trying to include enough of the parameters that we don't make it and then it fails and then we have to go back and say, oh, we didn't think about this, or this doesn't meet that parameter. Because the main parameter is the interconnection between the device and the humeral head, and how much like I don't want to get into like high level physics here, but the amount of so-called jump distance, like if you know total hips.
Yep.
So depending on the polyethylene and whether using a bipolar or tripolar, the so-called jump distance for the femoral head to get out of the cup, the higher that is, the less likely you're going to dislocate. So we want to have the quote unquote jump distance on this sufficiently so that the humeral head does not dislocate out of the device. That's a failure.
Well, three legs is the most stable configuration, right? It's gonna, the head should self-center into those three little balloons, right?
So yes, so that makes sense. But if you look at the design that's on the picture, the trampoline portion is below the midpoint axis. If you draw a line between all three of those balloons, it wouldn't cross where that trampoline is. The trampoline would be a little bit higher.
So even with the one that I just sketched, is that what you're talking about?
Yeah, exactly. However, leaving the trampoline where it is may be a desirable unintended consequence, because it may lift the humeral heads, correct, yes, superiorly, which is favorable, because the first time a surgeon is using this and they inflate it and they see the humeral head displaced laterally but goes superiorly, they're going to be sort of clapping their hands inside their sterile glove about, this is perfect. It just got the humeral head out of the way. And what's today? Tuesday. So having done this case twice yesterday, I can tell you that it's an inevitable problem for which they're presently. Now, when I was doing it yesterday, I was using a spider retractor, which is Smith & Nephew's product. The Arthrex product is called Tremano, which our hospital doesn't have Tremano. It has the spider. Another hospital I go to has the Tremano, and the Tremano is kind of, the spider is kind of painful to work with, but the Tremano is worse. So with the spider, you can move the shoulder in space and you can relatively distract it, but you cannot distract it directly laterally. That's not possible. So what the assistant is doing is they're taking their hands and they're putting it in the axilla and they're trying to pull the head laterally, which doesn't really work that well. So then they sort of try to pull it laterally and then they try to pull it forward to displace the humeral head out of the glenoid anteriorly. So that theoretically is desirable, because if the humeral head gets pulled out like over here, then I can come down here and fix these because the humeral head's out of the way. But I'm still going to bump up against it because you can't get it all the way, God bless you. You can't get the humeral head all the way out of the way. But you're still not moving the humeral head out laterally. And the problem with moving the humeral head out here, which you're either doing, so I'm talking about beach chair position. If you're doing it in lateral decubitus, then you're using there's a strap that goes across the forearm and it sort of, you put weights on it and it essentially does the same thing. It pulls the humeral head out laterally. And then what some guys do in one of the two positions is they take a bunch of towels, they roll them up, and then they put them in the axilla, and then they pull down on the arm and do a so-called nutcracker maneuver to try to force the humeral head away from the glenoid. So essentially, it's a jerry-rigged version of this, which is far more elegant. But everybody tries to do that because the anatomy demands that you have access without continually bumping in the humeral head and scraping it. And it just makes it like, I'm not sure if you know what a scorpion suture passer is, but you have to open the jaws. And I can just tell you, doing this all the time, it's really, really hard to open the jaws and push the humeral head out of the way to open the jaws. So then basically what you try to do is you sort of try to put it sideways and open the jaws, and then you sort of try to twist it around to get into the labrum, and it's painful. And then as you pull it out, you sort of scrape along the humeral head. But that's basically about the best that you can do with the scorpion. If you take a lasso, which basically has a sort of curved metal hook on it at the end of it, you pass it through the labrum here, and then in the middle of it, there's a wire that you thread through with your thumb, and at the end of the wire, there's a loop. And then you grab the loop and you pull the loop out through the superior porthole, you put suture in it, and then you pull it back through the labrum. The problem with that is capturing the loop, you need a second porthole, which is going to crowd you up in the front. Or what some people do is they take a spinal needle and they stab the loop with the spinal needle basically directly into the cartilage, so that when you pull it out, it doesn't pull out here, it pulls up this way. Because you have to remove the suture lasso down here, and as you pull it out, it pulls the wire with the loop out, which is not what you want. You want the loop to come out up here. So everybody struggles with that, because as you thread the loop through, it sort of will go out a certain amount, and then the part where your thumb is. So if you go to an Arthrex website and look at suture lasso, you'll see what I'm talking about. But as you thread the wire there, it then incarcerates and it won't go in any further. So it's less than ideal, but those are really the two techniques which exist. So having the humeral head out of the way is better because the loop, you can put the loop in further without it being deflected by the humeral head.
Got it.
So
Yeah.
those are really the considerations. So in other words, the circumlocutus route that I'm taking is that every surgeon has the exact same problem because the anatomy doesn't change and the result is the same. So if you can push the humeral head out laterally instead of nutcrackering it, in other words, when you do that, you're basically grabbing in the axilla and you're risking, a nerve injury because the brachial plexus is right up under there. And that is a known complication of putting somebody in traction, is you get a certain number of patients who you're doing a traction on the brachial plexus and they get hopefully a transient nerve injury. So if you displace it laterally, you're really not doing that. And the other more subtle consideration is that when you bring the humeral head out here, you're pulling the capsule asymmetrically. You're pulling the back of the capsule forward and the front of the capsule out here. Well, the whole point of the surgery is that when you fix the labrum, you grab the capsule and you're pulling it back this way. So you're kind of fighting yourself.
Yeah.
And so you really don't know exactly what your tension looks like on the capsule. You know what it looks like on the labrum. And so when you take all the traction off and you let the spider off or somebody starts pulling on it, the capsule may not be as tight as you think it is because you're repairing it under tension. So this is more elegant because the capsule from all the way around 360 degrees is being pushed laterally, so you have universal tension on it. So theoretically, you should be able to get a better repair. And one of the unintended consequences of displacing the humeral head anteriorly, which is what everybody, and I do because there's no other choice, is that when you put your first suture down here and you tighten it, then when you put your next one up here and you tighten it, this one might tighten the capsule more than this one because of the asymmetric displacement of the capsule. And then this one becomes loose because this one's tighter than this one. And there's no answer to that because you can't say, well, I'm not going to tension this all the way. I'll tension this and then I'll come back and tension this. There's too many sutures there. You wouldn't be able to control it. So you tighten this, you cut it, you tighten this, you cut it. And I've seen plenty of times where I've done all of these and then I look back at here, I'm like, damn, this one's loose now. And it was tight. And then I have to put another implant in. Well, theoretically, if the capsule is coming out straight and universally tensioning it, you might not have that happen, which is theoretically better.
So from a from a design standpoint, like, sorry, didn't mean to rush you. Since we got 3 minutes, I'm just trying to capture and thanks for explaining the constraints. So to kind of take that into consideration from a design standpoint, what do you like to kind of see next for our next call or next meeting?
So I think we would really probably get to the point of, the materials, what materials are going to make of. And then I think we ultimately have to make some, trials of this balloon, this, whatever you want to call it, distracting mechanism. So I think we're going to have to get some prototypes, maybe slightly different sizes, 2 or 3 different sizes, depending on how much it's going to cost to get them. And then I'm going to take this into a cadaver lab because the Arthrex guys keep needlingly like, hey, you haven't been in the lab for a while. Like, when do you want to come over? So I'll just say, yeah, like, set me up a shoulder. I'll bring these obviously with me. I've already done this when I sort of came up with the concept once. I'll bring the trials over, and then I'll use one of their implants to try to fix the labrum, and then I'll dissect the whole thing to make sure that it doesn't grab the axillary nerve. But while I'm over there, I will use these, and I'll take essentially pictures which can be printed of what it looks like when it's distracted.
Okay. So if I take this shape that I just sketched out here, right, doing a call, is this going to be the shape that you wanted to see with inflated and deflated versions?
Yeah, so I would probably make the one where it's in the center right there, and then the one that you actually have the one that's outlined and the one that's actually there. So I think if you can make 2 of those, like one of each.
Okay.
And then I think the first step is you can get a prototype and inflate it and see what happens. And then you have to go from there.
I think that I'm thinking out loud here. I think the trampoline should have a membrane. I think the trampoline should have an open hole. Does that make sense?
Yeah. So the open hole, I think, is good too. what I think of with the open hole is that there's going to be edge loading around the circle on the humeral head. And also the articular surface of the humeral head is now not covered by anything.
Right.
So as you pass the instruments, you could be dinging the articular cartilage, where if there's even a thin membrane, that you're protecting humeral head. And so I think a surgeon seeing that, saying, you know, wow, I can pass the instruments and the articular cartilage is protected. I mean, I can go into my bag right now. I can pull you out pictures I took of my case yesterday. And when I put the spinal needle in, you know, I skived across the articular surface a little bit because because you're doing that blindly, you can't see. And
so this is a meniscus implant that, you know, we developed at Active Implants, and it's about 1 millimeter at the bottom. And so if you kind of put it on a golf ball, I don't know if you can see this or not.
so I can see it. And yeah, that's like exactly what you want to do. I mean, yeah. So if you hold it that way, like up, it looks like you're crowning the prom queen. But if you hold it upside down, yeah, like that, or I would rotate it counterclockwise a little, like 90 degrees, so that the ball is in the, like that. So if you can do that and inflate it and push it up and it holds the humeral head, that's a home run.
Yeah. So this guy is only 1 millimeter. It's only 1 millimeter at the contact point, but it's got a complete rim around it. It's got hoop stresses, but we would replace that with three little discs.
So I think you could sort of you might be able to co-op that into design, like, because you've already done some work on that.
Yeah.
And
well, this unfortunately just comes in, you know, pre-made. It doesn't, I think the hardest part of this is going to be the uninflated design and then the inflated design. It's a 4D problem instead of a problem.
well, you can, once you make it, I can get you a cannula, because and you can then like, just without using a dab or anything, just in your hands, see if it passes through the cannula, and then inflate it, and then you'll know.
Is there any advantage?
Sorry to interrupt you guys. Sorry, I have to present for another meeting waiting on me. So
yeah, thanks.
I'll jump off and I'll catch up with you guys. Tiger, I'll call you back after this call.
Good. Right. Good meeting. Thanks.
Sorry to do this to you guys. Sorry.
Tell Rosetta hello. Okay.
Yeah. So that's my fault for being.
No worries. It all worked.
Too much detail, but I think that if you can make the prototype, I can get a purple cannula. That's easy, and then you basically can see, does it pass through that, and then what does it look like when it inflates? And I think once you have that, I mean, you can just do that on the tabletop.
Is there an advantage to using the Passport type cannula?
God, do I hate the Passport.
Yeah, everyone hates the Passport. It's awful. But if you superiorly in the Navage portal, because that's not really a working portal.
Yes, so it would be really hard to. So I wouldn't use a Passport in a Navage, and I was doing a rotator cuff yesterday, and the rep is always trying to talk me into using the Passport, because I think Rheingold probably made too many of them, and he probably has them in his trunk in his car in Naples.
People hate them. Yeah, I hear it. Yeah,
I hate them. I know the guy who actually designed a Passport is from Maryland, and you know, I was putting a dermal graft in on a partially repaired rotator cuff, and you know, he said, "Oh well, we have to take the Passport and we have to sew it into the skin so that it doesn't push into the joint when we pass the graft through it."
Wow.
Because it conceptually is a great idea, but from a working, like anything else, when you actually use it, it's miserable, because the rim on the inside takes up a lot of space and it obscures your ability to see. So you end up having to take the part that's outside the skin and sort of pull it away from the skin to try to take the inside rim and pull it up against the deltoid just to get it the hell out of the way. So I hate the Passport. It almost always causes more problems than it's worth. And the rep will say, "Oh, well, you're not going to get a soft tissue bridge." And I'm like, you know what? I'll deal with a soft tissue bridge.
Right.
So I said, look, I could probably, in the 36 hours, design something better than the passport.
Yeah.
And I'm working all these other designs, so I don't have time to do that. So, but in any case, I think if we get the prototype and see if it goes through a purple cannula, or and it can be inflated and inflates the right way, I think you're 3/4 of the way there.
Yeah.
Then I'll take it into the lab with the cadaver, and I'll just see, does this really displace the humeral head laterally? And then I'll give you feedback. Unless somebody wants to show up, I don't think anybody wants to necessarily come to Maryland, but I'll take pictures of it. I can take video of it and put it on a chip, and then you can see what happens. Does it displace like you want it, or is it not do that? And then what do we have to redesign it to account for that?
Right.
Mhm.
But for
Okay.
all the reasons that I gave you before, if you can make that work, it's hard to imagine that any surgeon seeing that for the first time, not saying like, oh, well, I'm not going to use this. It's going to be in the way.
Mhm.
I think
It's
most people.
it solves the too many hands problems. Basically gives you hands-free distraction. Where it's a no-brainer. It's a total no-brainer.
So even if you just used it yourself, in other words, surgeon X just used it itself and never told anybody else about it and never showed it to another surgeon, everybody would know about it because the scrub tech and the PA in the case, they're going to go in the next case and say, oh my God, you should see this thing that Dr. Weiss used. It was so much easier. And most guys will say, yeah, let me try that. Let me see what it's like. So, I mean, the word would spread. If you do it right and get it right, it would be the old Breck shampoo thing, I did two people tell two people. Yeah,
Viral. It's a viral tool. Cool.
Anyway, I appreciate your time, and I know I talked a lot, but I was trying to have everybody think about all the confounding problems simultaneously, and we have to take all of them into account.
Mhm.
Yeah, the details is terrific because it's like you said, there's competing requirements that are tug of war. So if this were easy, anybody could do it. So we're going to figure it out.
Yeah, I think we'll have a pretty large moat in somebody trying to copy this. Obviously, we're going to once we get it right, we're going to do provisional patents and things on it. But it'll be hard for somebody to copy this because there's such a limited number of things that would actually work. I think if we get it right and it becomes very popular, then somebody's probably going to want to distribute this and ultimately buy it from us for probably a pretty large multiple.
Yeah, I agree. Devil's in the details. We got to keep iterating and figure it out.
Yeah, so the hospital VAC, you guys are familiar with the VAC.
Yeah, we hate vacs.
Yeah, everybody hates the VAC, but the hospital VACs can say, well, you're adding a cost on, or the surgery center, you're adding a cost on. And the answer is, no, actually, I'm not, because you don't have to use the Tremano, or you don't have to use the Spider, those parts that you put around, which are disposable, are pretty expensive.
Mhm.
So no, actually, it might end up being cheaper.
What do you think the price would be? I mean, it's a hard question, but what would be the tolerable price for a disposable instrument that did this?
So I can get a little bit more information on that about what the tolerance is, but the Arthrex reps are going to know that because they're always trying to get something in. But I think a cannula is something like $80 to $110, depending upon the cannula, and the hospital obviously has no problem with that. I mean, everybody uses a Scorpion, and there's a disposable needle that goes with that, and that's like about $100 and something for that disposable needle, plus the suture. So I think if you're somewhere in that sweet spot, and actually I can ask, I'll ask the orthopedic nurse, what does the disposable Spider part that you put around there, what does that cost?
Mhm.
And so that's a really good baseline because we're going to substitute it for that. So that's a good price point, plus how much does a cannula cost? So that's going to give us, I think, a working number.
We may be able to bump into a higher price because it should shorten the OR time, right?
Yeah, so in my hospital, it's $36 a minute. I don't know, an ASC might be a little bit less. So yeah, you're going to make that argument is that you're going to struggle a lot less. And also the real cost is in manpower, because I am going to be able to free up a set of hands such that I may not even need the PA. In other words, to be pulling on the arm, I can just use the scrub tech because the PA or SA's job has sort of been made obsolete theoretically. So if you present that, the cost savings in terms of manpower would be huge.
Yeah.
Yeah, it solves a real problem. Manpower, time, struggling, materials. Yeah. I think we got.
I think depending on where you make this, Vietnam or wherever it is, or Wausau, or whatever your inclination is, I think the cost of making something like this, it's probably going to be like $20, or I mean, it's just a piece of rubber. So.
The challenge is volume. So if you're going to make 1,000, it's going to be pricey. If you make 10,000, it's way cheaper. If you make 1,000,000, then it's, that's the challenge.
Yeah, so you're talking about the margin. So what's going to be your margin based upon how many you make? So yeah, so that's going to be a consideration. But I think the marginal price of this device is probably $10 or $20. The cost of making one more.
Yeah.
Economic theory. So
you sort of have to amortize the tooling. I think that's where the cost.
Yeah, that's gonna be the how it's not fluid dynamics. We're not using saline. I guess we would use air or
probably injection molding would be my guess, is what this.
But that controlling the flow, to your point, of which inflates first and all that sort of stuff is going to be define the manufacturing process. And if there's any sewing involved or anything like that, that's obviously going to increase it. But I think ultimately this is in high volume, it's all automated. First prototypes are going to be expensive, but I can see the first prototypes being around maybe sterile on the shelf around $100. But that's not brutal.
Yeah, so I think once you've amortized off the cost of the manufacturing devices, it then becomes almost pure profit from then on.
Yep. And no, you don't need a rep. It's sterile pack shipped to the hospital. Well,
the rep for whichever company you're using, basically Smith & Nephew or Arthrex, is going to be there anyway. And, I mean, if you can't figure out how to put the balloon in and inflate it, then you probably should be asking, would you like to supersize your fries?
Yeah, well, this is great. Thanks.
Thank you. Appreciate your time.
Yeah, we'll do it again soon. Thanks.
Great. Appreciate it. You guys have a good day.
Thanks, you too.